morning, everybody. How are you all? That's great. My name is Stuart Schlossman. For those that don't know, yes, I too have multiple sclerosis. Today's program, we fortunately get lots of grants to do our programs. The pharmaceutical industry loves MS Views and News for the types of the programs that we're providing, the speakers that we bring in for our programs, and the audiences that we do have at our programs. So for today, I would like you all to help me thank Sanofi-Genzyme for doing today's program. Woohoo! Okay? Great. All right, and other than Sanofi-Genzyme, we did have a lot of exhibitors outside. I hope you got to see them, and I hope that you were able to obtain information from them that you may not have already known. Today's program, we do have some slight changes. So originally, we were going to have Dr. Berkovich, but she couldn't be here today. So we brought in Dr. Ansari, and he's here to work with us today. And we also were going to have Dr. Amezcua, who is here today, who was going to speak second, but now she's speaking first. And for now, I just want to introduce Dr. Amezcua. She's the Associate Professor of Neurology in the Division of Multiple Sclerosis. She completed her medical training at Jefferson Medical College in Philadelphia and Neurology and MS Fellowship at USC. She also has a Master's in Clinical and Transitional Science Epidemiology. She's currently the Director of the MS Fellowship, runs clinical trials in MS, and leads NIH and NMSS research projects in the diverse populations. Let's welcome Dr. Amezcua, and let's get started. Thank you.
Well, thank you so much, Stuart. I've gotten to know Stuart maybe over the last year or so, and it's inspirational to know what he's developed and what he's doing, and now being able to expand across all of the U.S. I'd like to see him more on this West Coast and doing more programs. I am at USC, for those that don't know me, and I know some of you do. And today I'm going to focus on talking about what makes an appointment a success and over time, these appointments. And this is based on some of the topics that Stuart sent to me requesting that I should touch upon. And so this is what the topics were. Effective communication with your healthcare team, that is what we're going to go over. We're going to talk about creating long-term trusting relationships, because I do think that they're really important. I mean, multiple sclerosis, right? It gets diagnosed. Now you have to be part of a program or a healthcare team that will be seeing you not just once, but for a long time. We have to talk about the priorities and goals. And believe it or not, priorities from the patient may be very different from the priorities that your physician may have. So I'd like to go over that. We'll also go over a little bit, how do we break down medical jargon? We as physicians, we like to use big words, right? And we're always trying to figure out how to break them down to more words that can be understood, particularly when we're talking about, mechanisms of action in the immune system. The immune system, believe it or not, it's even complex within physicians. So if you are not an MS specialist and you're just a general neurologist, your ability to understand the immune system will be less. And so it's not just for the patient, but also for our referring physicians. And then we're going to go over about understanding your options to gain a better understanding of your MS. And all of these things that were planted by Stuart to me, I really do think that if we know a little bit more about them, that's what leads to a successful appointment and care of MS. So how many of you out there have MS? How many of you out there are caregivers to someone with MS? And all those that are here to support you, we have to, give yourself a big applause for everybody. So having MS is scary. And But, something to note is that you are not alone. Right now, it is understood that about 400,000 individuals in the US are affected with MS. We really do believe that those digits should be doubled. And there is information that we will be getting soon that will we will have a better prevalence number. But this is about 2.5 million cases in the world. Most of these cases reside in the northern parts of the equator, right, because of the risk factors that are associated with MS. It's commonly diagnosed between the ages of 20 and 50. Anybody that was diagnosed below age 20? So a few of you, and so those that are aged below 20, it accounts for about 5% of all cases. But now we're also diagnosing them above age 50. How many of you were diagnosed after age 50? And you probably had symptoms way before, but it wasn't diagnosed until then. So really, the disease likely started in the ages that I'm talking about. But we now understand that overall individuals that have MS above 60 may account for about 10 to 15% of cases. And so with that, we also have to start thinking about not just MS, but MS and aging, because with age, other factors come about that relate to health. It's important to realize that MS is nobody's fault. This is not because you got something from someone. This is not because of what your mom did when she was pregnant. We do understand that there are certain genetics that are important. So meaning it's like the signature that you were born with that makes you more at increased risk of having MS. And then it was the environmental factors that so far we do know a few, but we don't know it all. But we certainly understand that MS is not caused by one thing. It's going to be multifactorial, right? There's the genetic signature, and then there's the risk factors that somehow came together, these environmental factors, epigenetic sort of development that led to an aberrant immune system. And so it's important for others surrounding you to know this, that it's not contagious, and that while we do not have a cure yet, we're getting there, we're hoping, we're getting closer, that we do have treatments out there that if started early can lead you to a very functional and almost seemingly cure type of MS. MS, as you know, is the result of basically your immune system attacking areas of your central nervous system, right? Primarily the myelin. And your central nervous system is your brain, your spinal cord, and your optic nerve. That's why you may hear about optic neuritis. And here's the most important part of MS, is that it's not the same for everybody, right? Everybody may present with different symptoms, may have different challenges than others, and so, and this may be related to the course of MS. Most of them are relapse remitting, which is 85% of the cases, and then you have the progressive forms, which we're trying to get a better understanding. But all of this is really important to actually know and realize that, one, you're not alone, but we are here as a team hoping to better understand you and work with you. So how do we establish effective communication with your doctor, with your nurse, with your healthcare team? Well, first of all, and I know Dr. Ansari will later on talk about, who is your healthcare team, right? What leads to a comprehensive way of caring for you? Because in MS, we as doctors, we need to know about MS, but we also need to be able to know about other systems that may be involved, such as the bladder, which later on we will hear about. But it's important to note that it's not just the communication coming from me and coming from my nurses. You as a patient have to also be very assertive and be able to talk to us and tell us what are your needs. You have to be clear and honest. Sometimes honesty is difficult, and it just may be because there are embarrassing type of symptoms that you are not yet sure to express or know how to express and talk about them. And these, Some of those are going to be obviously related to the bladder. They may be related to the bowel. They may be related to sexual and actually even emotional types of symptoms that makes it a difficult dialogue, specifically if you don't know your team well, right? If you still haven't had the rapport with your physician, this can be very difficult. But having that open dialogue is important. And then asking questions, right? You need to be able to ask your questions and be able to let us know that you understand what we are talking about. But of course, it's also for us to be able to ask that question, did you understand this? Do you, for you to follow what we are indicating with. And believe it or not, I mean, 70% of errors can be because of ineffective communication. And so we don't know that in MS, but this is in general with different types of care. So the doctor-patient relationship, right? Honesty is the best policy. That's what I just said, honesty, clarity. But when trying to be honest is also, you need to build trust. And so you need to, when I see my patients at the beginning, sometimes I do say, well, I'm going to be seeing you from now on. This is not just a one-time visit. This is from now on. Our average is every 3 to 6 months. You will be coming here, and I want to make sure that you're communicating with me. If you're having new symptoms, if you're having some issues with the medication that I gave you, or there's a misunderstanding, you have to be able to tell me. You have to, I want you to feel comfortable with me. If you don't feel comfortable with me, then maybe we need to find somebody else, because this is a relationship that we want to build over time. And I can tell you, the better types of more successful and more cases is when somebody feels very, comfortable with your physician and the nurses and the care that you're getting. So again, building that healthy rapport with the doctor, in my opinion, is that, again, goes back to the honesty, telling the truth. And here, very focused on MS, we can start off with just focusing, okay, when you go to your visit, you can focus on several aspects. First, we can talk about the physical aspects of MS, right? So what changes are occurring? Are you having more motor problems? Are you having more sensory problems? How is work going? And I will sit there and sometimes talk about, tell me what your day looks like. I want to know what your day looks like. How's it going at work? Or if you're at home, what are the usual activities that you're doing? Just so we can get a better sense of your being more problems and disability. Let's talk about those bad habits as well. And this comes usually after a time where the patient may ask me and say, well, what can I do that is natural to take care of MS? Well, let's talk about those bad habits. I mean, if you're a smoker, smoking is bad for MS. We know that it's significantly associated with higher risk of progressive disease. That is well known. And then let's go over other social types of behavior. Why are we seeing some liver enzymes being higher than normal? Is there a component of alcohol? And so those things are important to go over in the visit, because again, the healthier you are outside of your MS, that will also lead to a better state for MS as well. What about fatigue? Fatigue is so common in MS. 90% of MS patients have fatigue issues. Fatigue itself can be coming from other problems. So, for example, a patient that has a lot of spasticity will have more fatigue than the one that does not have spasticity, because spasticity means that tightness, that cramping maybe in the legs or arm. When you're walking, you're feeling like you have sandbags in your ankles, perhaps. If you're feeling that, then you're using more energy to walk if you were without spasticity. And so the treatment there is really not a medication for fatigue, but you need to target the spasticity and work with physical therapy or work with agents, medications that help the spasticity. Another example that can affect energy levels, of course, is bladder dysfunction, right? So if you're having to wake up about 2 to 3 times at night to empty your bladder, then you're not going to have a full night's sleep. And in the morning, there might be possibilities of, again, increased spasticity or just overall fatigue, right? So we have to usually, as a physician and nurses, we need to take a look at MS as a whole. What else is going on? What else might be explaining the fatigue to better take care of that issue? And then we need to be open about your feelings. About 40 to 60% of patients with MS can have depression. And so that's a big number. And usually when you think of depression, you're thinking about, the typical type of depression, right? Not wanting to go out, crying all the time, sort of this emotional lability. But in MS, it may just present differently. It may present just overall as a generalized fatigue, not anything more. And so we have to, again, sort of discuss this. We have to evaluate your support system so we can get better at identifying what's the problem and lead you to the best therapy. But again, talking about your feelings may be difficult at the beginning. How can we improve communication? Well, you have about, 30 minutes? If you're at Kaiser, you have 15 minutes to talk to the doctor, right? Not a lot of time, right? So, and I used to do this before medical, records were all electronic, was that I had a one page where my patient would fill out before they would come in, and it included, was there any new event since your last visit? Is there a new medications? And then I also would ask them to jot down the 3 most important questions they would want to have answered that visit. I thought that was really helpful. It was really great. But then, electronic version comes up, but I still like that. It's like if you have a list of questions already to talk about, it just makes it easier. And so I love it when the patient comes in and says, "Doctor, I have my list of questions." Like, sure, bring it up. Just open your pages, and we talked about what I want them to do, and they'll realize that I probably already answered some of them. And so they check mark them, and then it's like, oh, but wait a minute, I have this other question. And I really, really do appreciate that because I feel that now my patient's going to be able to go home with, again, their questions answered. And it also makes me realize that, they're understanding what I was trying to tell them that day. Of course, having somebody there with you on your appointment is also very helpful. And of course, that may be more for advanced MS, right, where there's a caregiver involved, because it's not only what the patient reports, but it's also important for us to learn what the caregiver is having difficulties with. Perhaps, again, let's go back to that spasticity, since spasticity is so common in MS. If they're having a lot of spasticity between, in their thighs and their legs, is it becoming much more difficult to clean them? That is important for us to know. The patient may not realize that, but the caregiver will understand that. Or sometimes the caregiver will actually let us know that, well, I think, she's more depressed than before. I'm not seeing her engage in the activities that we usually go to, or having some, crying spells or laughing spells, which is known as pseudobulbar affect, which can happen in MS. And so those are really important things that can come from the caregiver's observations. So it's, again, having somebody with you at the appointment can give us a lot more information. And like I said, writing down your doctor's answers, sure, I'm okay with that. You can have your phone as I'm talking and letting you know what should be the next, step to your care. Sometimes we will write things down, but most of the time it's usually the patient that will be writing in their own notes when we're discussing. Of course, sometimes at the beginning of the first sort of appointment, there is a lot of information overload, and I understand that. And so sometimes it's important to bring the patient back in from our standpoint a few weeks later and then be able to talk to others, such as our nurses, for education about a specific therapy. Because, as you know, our therapies are quite complicated nowadays. We have more than 15 drugs that are FDA approved for MS, and so each one has its own side effects, its own safety profile, and follow-up, and pre-prep before you take the drug. And then it's important to note that also there is others that are part of our team that can answer some of your questions. If, like, let's say a question pops up after you saw the doctor. And so at USC, we're very fortunate that we have an MS nurse, so a nurse that was trained in MS, dedicated to answering all of our patients' questions as best as possible. If she's not able to answer it, then it usually goes to the next step, which is usually our nurse practitioner, who is also MS trained, that can answer the question. If there is a further step needed where the physician needs to be involved, then one of our fellows or ourselves will be called, and then we take care of it. And so it follows a very systematic view. A lot of it, again, sometimes it's medication side effects or perceptions that a medication is causing a certain side effect when maybe something else is needed to be done. But again, remembering that nurses, PAs, pharmacists are also really good resources of information. And of course, even those that distribute some of the medications. Always before you leave your appointment, I think it's important usually for you to leave with your follow-up already established, even if it's 6 months or to a year. Let's say you're doing really great, and I might say, it's like, hey, I'll see you back in a year. This is really good. Believe it or not, we do have those patients. There's a lot of, very, very great responders, and so we may just see them once a year. So I usually always say, just make your follow-up appointment. It's easier to cancel than to reschedule last minute. And of course, be able to note, when do I need to call? And that's usually one of the most frequent questions I have after a new diagnosis, right? So when do I call? Who do I call if something is wrong? You just went through a relapse, your first relapse. And so you'll be very apprehensive with, the new, symptoms that may be appearing. And so we, again, at USC, it's sort of absolutely at the beginning, new symptoms, go ahead and give us a call. And then if we think it's a sort of nothing, then we'll just tell you it's nothing. But I rather do that. So some of the questions that you can use, to guide you is basically always be certain. What is my diagnosis? If you're uncertain what your diagnosis is, be sure to ask. Do I have MS or do I have a variant of MS? Because there is variants of MS, right? An atypical form, or if there's an NMO. And of course, ask your doctor, have you treated MS patients, right? Or have you treated MS patients with this specific drug? It's important to note that as well. The side effects, the treatment options, all the way to cost. If there's a cost issue, sometimes we do note what drugs have patient assistance programs. So that is also important. And then breaking down medical jargon just comes down to making sure that you're assertive and say, hey, I really didn't understand that. Can you go over that again? What does that mean? Can you show me some graphics of your graphics? First of all your doctors should be able to be sharing your MRI. If you've never seen your MRI of your brain with your doctor that's treating your MS, you got to show that. You got to know your brain. Be able to, again, maybe say it back to the doctor. If he feels like, what, I think I understood it. Did you mean this? Go ahead and say that. And then that way we're able to also understand that you understood what we were trying to say. So, and of course, I like to, like I said, the first day may be a lot of, information overload. That's why I never usually say what medication you're going to go on in the first visit. I usually will come back. We'll have you come back a few weeks later to go over more in depth of the possible medication that I'm thinking about, because there's certain labs that need to be done. But I also want you to do your own little homework, because again, this is going to be a relationship. We want to be on the same page. And so, of course, going to the nonprofit organizations that can give you some information. Believe it or not, even Amazon, if you have the Echo, you ask Alexa to give you some facts of MS. It's available. And then we can go over, when you come back, some of the information that you read, and does it make sense, and if you understood it. Because the more you know MS, the better you'll be able to reach, better treatment. So these are some of the treatments of MS. There's injectables, there's orals, there is infusions, right? This is not MS from the 90s where it was only injectables. Some of us may not even use certain, injections anymore, because there's, the oral therapies. And again, it's going to be a decision that you have to, sort of go over, okay, what is my daily activities like? Where do I work? Am I able to take a day off for an infusion or not? Or do I just, when I want to go with the safest drug in, so far, maybe, that may be the injectables. Or, so it's going to be different reasons as to why you go on the therapy. I will tell you, I use every one of them because there's a place for each one. Remember, now what we're striving is not just your treatment, right? We're striving for wellness. Wellness is about also knowing your environment. What is everything outside? We want to learn about that. We want to learn that what you're eating. We want, and again, about your habits and what things can lead to better. And this is from June Halper from the CMSC. Weighing your options, eating well, living to your fullest, learning new skills, needing others. So being not afraid to say, hey, I need help. Evaluating situations realistically, surviving stress, right? Stress is important, learning how to manage it and cope it. We can't get rid of it, unfortunately. And just being on top and staying responsible with what is suggested. Some of the things just to, lastly, is to remember that, obesity is a risk to MS. That's now, been found, particularly in adolescents. We don't know its impact once you have MS, but we certainly believe that, weight management is important. There's this notion of increased sodium intake also as a potential factor. So when it comes down to saying, doctor, what can I do about my diet? And I said, well, perhaps, having a normal BMI is important, or getting to that normal range, lowering that salt intake, making sure your vitamin D is on the right number, and then the microbiome. Everybody's hearing about it, right? So the role for probiotics, there's a role for that as well. And then emotional wellness. That's going to be more difficult for me to take care of, but certainly we are there to hear about it so we can give you and provide you the right referral. Is it just, being part of a support system that can help you, some counseling? There's actually even telephone delivered physical activity counseling that's out there that's for free by some of the National MS Society programs that they do. And then just, stress management at USC, we have the Living Well program with MS. So that can also be helpful. So in summary, it's, focusing on the topics that Sarah gave me, it's really, it comes down to know as much as you can about MS. And be able to be prepared when you go to your appointment, basically. And we are here. We want to listen. We want to hear what's affecting you, because that's the only way that we'll be able to see, are we treating you the right way with the right medications or not? What else do we need to be able to do? And then, of course, we are also on the road to striving for wellness for you as well. And that's it.
Great, thank you. That's not it. Now we got the questions, right? Who has a question?
Here with USC, UCLA, a lot of times residents, because they're teaching hospitals, there are rotations for the residents, so a lot of times you don't see the actual doctor immediately. What's the best way to handle that so that you don't lose that dialogue between your patient and yourself?
That's a very good question. So at USC, actually, we have specialty MS clinics. And so usually you do not get the resident. You will get neurologists that are training in MS as opposed to doctors training in neurology. So way steps down. And so it's a little different. I can't speak for the residency part, but one thing that I would suggest is that, make sure that when that resident, because I imagine that resident would go back to the station and discuss their case, right, with the attending doctor, that is the MS specialist, and when they come back and say, okay, we're going to do this, and if you feel that there was something that was missed, tell them and say, but wait a minute, I also, did he say anything about what to do with my fatigue? And then if you feel it's not answered, then so is there any way that I can speak briefly to your attending, because it seems like you're not listening to me? I would say that. I like to say that from the fellowship, it's a little different, because these are fellows. These are already like in their first, second year of MS. And so usually you will always either get, you're going to get a little bit more specialized care because it's already MS. And you will always, like right now I run the fellowship, and with Dr. Ansari is basically, I'm there as well. So after the fellow comes, I have to still go in and talk to the patient. And sometimes, my patients, you might be able, not know, I'm telling you now, I might do a little extra things that if I felt like, what, let me check, Dr. So-and-so said that, he saw a little weird thing in his eye. And it's like, and so I'm going to double check it and see if it's true. I may do that. We may, again, review the MRIs together, and it's part of the teaching method, but it's also about confirming what was presented to me, the most important findings. But yes, those are important questions, and, that's the difference, I guess, between UCLA and USC.
Okay. We're going to go around the room. I'm going to go over here next. And please, everybody, try to remember, don't make this about you. Just make it general questions, all right? This way the doctor can answer.
You mentioned depression, and I'm curious about how depression differs in MS versus depression in the non-MS patient in terms of both its cause and its treatment.
Yes.
And the effect that it has.
Absolutely. So very, very good question. So for depression and MS, we think about it as being either primary or secondary or even tertiary. So meaning, what is causing the depression and MS? One, it can be that, in fact, this individual already had depression from even before MS. So sometimes depression even starts in adolescent, right? It's going to basically be a little bit different as opposed to in terms of when it started. So, right, it may also have already other elements that were there, particularly if it's major depressive syndrome, right? What constitutes major is based on the length, and then if there's been some other features of depression. Sometimes the depression MS is very subtle. So it's not necessarily meeting all the criteria, perhaps. And this can be because there is side effects of other medications that may put you at risk, into this sort of depressive or what we say flat affect that you may see. And then, of course, MS in general, if there is, over time, there can be more depression because of depending on the white matter that's being affected. But the treatment is the same. The treatment right now for depression is the same, and it's usually involves either, a combination of antidepressants and it depends, of course, if there's an anxiety component or not, or, counseling, one-to-one, right, psychology or group therapy, depending on what the depression looks like. So, from our standpoint, is more of like identifying, is this sort of a primary depression that we need, sort of more help from psychiatry, or is it a little issue of the side effect that we're going to try to control if they're doing really well with the therapy, or make them, or perhaps take them off, or lower the dose of the other, sort of afflicting medication. And so it comes down to that. But yes, I mean, the prevalence, like I mentioned, is 40 to 60%. But I do think in my clinical experience is that some of it is just very subtle, and it almost like, if you're diagnosed with MS and over time, some of them, it's almost like, oh, there's depression, but we couldn't see it. So more subtle than, the other form.
Next question here, please.
You mentioned earlier about probiotics. Is there a certain probiotics that you would suggest, or will any of them be okay?
Right now, I do think that it's very early on to say what specific probiotic you may use, but there's a lot of interest in that, and I think we'll be able to get to that information soon. But as of now, I wouldn't be able to say what probiotic. I mean, the most typical probiotic is the lactobacillus, and so I would just recommend that you do not overload yourself on probiotics. Now, you can do it through pills, or you can do it even just with, sort of yogurts, right? The yogurts that have that probiotic component, those are good sources.
Next question.
Hi, how do you get a neurologist that specializes in MS through your healthcare?
Yes, so at USC, all you have to call is 323-442-5710, and then you will say, I need to see multiple sclerosis, and they will forward you to our center. There is certain neurologists out in the community that by default are, sort of doing a lot of MS because they have gained experience by seeing a lot of patients. So I know that there are some, and you can, if you're uncertain if your neurologist is an MS specialist, you can ask them, were you trained in MS, one, or how many patients with MS do you care for? So you can get a sense if they, are being exposed properly to the MS field. We do have, like I said, we have the private institution that sees MS patients in our center. We're the same doctors at the LA County Hospital where we have an MS specialized clinic. And then we also have Rancho Los Amigos Rehabilitation Center in Downey that also has an MS clinic, an MS specialized clinic, and all of them are us as specialists.
1 minute.
The donut hole for medication used to be 4,000, then it went down. Do you know what it's going to be for 2018?
Oh, that I would not know. I don't know if anybody else would.
It's a trick question.
It is a trick question. But hopefully it doesn't change much, but or changes a lot, but to the good, right?
Right. Okay.
Next.
I have a question regarding at what point do you decide to call your neurologist or your general practitioner? So let's say if somebody has, I'm a caregiver for my husband and he has high fevers and he's having neurological issues due to the high fevers, should I be calling his neurologist or his general practitioner at that time?
Yes, very good question. And we get them all the time because, of course, we're on call, right? So usually, yes. So when there is constitutional symptoms, which includes fevers, you have a really bad cold, right, or a bad infection, what's going to get worse, or you may actually start even without the sort of those symptoms like fevers, but more of a worsening of MS. So usually we're going to say it's like, and let's say you tried Tylenol at home and he's not getting better, we're going to say to call your primary care doctor. Of course, if there is worsening of symptoms for MS in the absence of fevers, infections, anything else that might be, sort of promoting them, then that is when we get concerned about a relapse. However, you shouldn't feel afraid to call either of them, because we can be on the other side, or our nurse might say, it's like, go ahead and call your primary care doctor. So just, if you're uncertain as to who to call, don't be afraid to call either one, and then we'll be able to tell you what to do.
Next question.
Hi there. This is probably a tough one. It's talking about how to convey issues of cognitive function. Either it's COG-FOG or executive function impairment. Happily, our doctors don't suffer that, but that's a hard one to convey the detail of and the effect it has on daily living. So just if there are any hints about what words you need and what helps you understand.
So usually, like, let's say a patient may come and say, my cognition is getting worse. And so my next question is, well, what do you mean by cognition? And so we want to know, you don't have to use big words or anything, executive function, right? They're not going to be able to say that unless you're in the field and know about that. So you then ask them about what their daily life is like. What are you having trouble? Are you having trouble remembering tasks? Is it about tasks, multitasking? Because usually that's the issue, right? It's multitasking. Or is it an issue about focusing, right? Focusing, multitasking, of course, remembering names, remembering, etc. And then we'll make our conclusions like, it's a lot of focus and attention. And then you look at their affect and it's like, that's where you might be cluing that maybe there's a depression. And like we said, depression is 40 to 60%. Guess what? The number one reason for cognitive worsening is actually depression. It's a superimposed depression, okay? So we have to almost like clean it up first and then be able to say, okay, what is also wrong about their cognition? And so usually things that help us out, identify better, is through neuropsychological testing, which is like about 4 hours type of testing, and they do the different tools. And then they might be able to say, they have intact verbal, they have, they'll tell you the different domains, and that's where we are able to say, this is actually just depression, a superimposed depression that is causing their cognition to be worse. Or it's like, okay, there is an executive issue, this is how we're going to work it with, neurocognitive rehab, etc. But yeah, it can be very difficult to sort of separate them out.
Are there any other questions? Whoa. Any other questions here? Well, then guess what? You're going to get to go to the recital even quicker.
My 11-year-old and 9-year-olds will be very happy.
Thank you very much for coming down here today. We greatly appreciate it.